Cool. All right. It's 11:01, so we're officially at time to get started. As people are trickling in, that's totally okay. And if I miss somebody, please admit them. Healthcare team. Hi, everybody. Thank you so much for joining our foundational training today on connecting people in encampments to healthcare resources. We're so excited to talk about this topic. I know it's come up a few times when we've met with communities. And I think this would be really helpful and useful for everybody here. So without taking up too much time and space, I am going to go ahead and introduce our home-based healthcare team and connect it with Julie. Hi, Julie.
Hi, good morning, everybody. Thanks for joining us today. I'm joined today with my colleagues, Jillian Morchetti and Alyssa Weiss, and we're going to be talking about a whole range of healthcare things, specifically about how healthcare impacts people experiencing homelessness living in encampments. So thank you all for the work that you do, and we hope that by the end of the day, we're providing you some resources and information that will help you feel even more equipped to work with your clients living in encampments. So just a quick reminder about Zoom, and our team is really good about literally doing the visuals, but we have closed captioning available, which you can see the arrow points where that is. We are recording this training. We are very much a group who does not mind to be interrupted with questions. So you can put it in the chat and my colleagues will be watching the chat. You could use your virtual hand, and the arrow down in the right-hand bottom shows you where that virtual hand is. And then you can just unmute and interrupt and ask a question. And then if you have any tech issues, send a message to Maddie or Sarah. Okay, so today we really want to provide a foundational training to help you all better understand sort of the impacts healthcare has and the opportunities for you all to help people access healthcare resources and the importance of some of these healthcare resources to helping people move to more stable and more self-empowered living situations. So we'll talk a little bit about basic healthcare sources, how health system partners can help, and who they can help, and then how encampment resolution case managers can assist people living in encampments access key health resources. I'm going to talk a little bit, like some of this information is going to be basic, and there's a likelihood that you all know a lot of what I'm about to say, but we want to make sure everyone has the same foundation as we start to dig a little deeper into the details. So be patient if you feel like you know this. We are going to get to the stuff that you don't know, but we just want to make sure everyone has a shared understanding and context for a lot of the benefits that we're going to talk about. So as most of you probably already know, people experiencing homelessness are at greater risk for poor health for a number of reasons, by living outside and having close contact with others living outside. They're more apt to get communicable diseases and infections. Of course, living outside is extremely stressful. Living without stable housing is extremely stressful. So they're exposed to more stress than those of us who are housed. And then in addition, access to food is limited. The weather conditions that impact living outside, you all know a lot of this. They lack running water for refrigeration, for their medications, that's often an issue, and then for cleanliness, and then just access again to food. And because of a lot of these issues, they're around other people with communicable diseases, and they just have higher rates of a lot of health conditions, chronic diseases, infectious diseases, acute illnesses. It's really difficult to live in these situations. So impacts on mental health or turning to substance use to cope with the situation, and then also exposure to domestic violence. So there's a lot of impacts, and the reality is that their mortality rate is 3 to 4 times higher than the general population. Excuse me. And we talk a lot, and UCSF has some good data about, people at 50 living unsheltered present with physical issues that are closer to 70 or 80-year-olds. And so that's really important to consider, just like the impacts of this situation on stress and health. Next slide is they also, in addition to having more health issues, right? More health issues, less access to care, which of course exacerbates the health issues and it becomes a vicious cycle. But our systems that exist currently, especially homeless assistance and health systems, aren't necessarily in coordination and collaboration. We all are working on that. That's part of what today is to help empower you all to do more coordination with the health system. But what happens is that means people, there's missing information in the homeless system. Often the information we have about people experiencing homelessness is self-reported. And so they may not talk about a substance use problem because they might be stigmatized or be worried they might not get assistance. They might not tell you about a mental health problem, or they may not recognize some of their serious health issues. And without talking to health providers, that you might not know they have those issues. Also, the two systems aren't coordinated, so there's often duplication of efforts, and that can be all consuming to people. They have enough going and they don't need to tell the same story twice or figure out which appointment they have depending on it not being coordinated. And then also because of that lack of coordination, they can fall through the cracks and not get connected to resources. And eligible and cabin residents are not consistently enrolled in the benefits so that they can engage with healthcare services. So you'll see when we talk about who's eligible, that there's some benefits like CalFresh, that if you're eligible for CalFresh, you're eligible for health coverage, but you might not get it because you're not on CalFresh. So altogether, without healthcare, it's really challenging to achieve housing stability and stabilization overall in their lives. So in that context today, what we're going to do is we're going to give some basic information about health coverage, about Medi-Cal, some of the basics about it, some of the new benefits and services that have been introduced in California for people experiencing homelessness, and a little bit about how to prevent people from losing coverage and some ideas about how to make sure everyone has coverage. And then we're going to talk a little bit about the healthcare delivery system outside of Medi-Cal and some of the other opportunities in street medicine and how to find local providers, and then have opportunity for questions and discussions at that. So we'll go ahead and start with healthcare coverage, Medi-Cal 101. So you often hear Medicaid. Medicaid is a federal public health insurance program that provides health coverage to all sorts of people, families with children, seniors, people with disabilities, pregnant people, people in foster care, people with specific disabilities. It's a program that's jointly funded by the federal government and the state, and much of the program is funded by the federal government. And then the state enhances that both with matching funds, but also with additional services, depending on what state you live in. And we'll talk about the benefits of being in California. But because it's a federal program, the rules, the eligibility standards, in most cases are governed by federal regulations, federal law, and policies. But each state can enhance that, adapt that. Some things are optional. And the payment rates are by state, who the providers are by state, and then often the scope of the services. Well, there's a basic service that all states have to do. Some states and many states offer more. States can't deny or reduce coverage based on an illness or a condition. So there's no such thing as pre-existing conditions in Medi-Cal. The services that are covered are medically necessary, and federal government has a list of what those medically necessary services are in general, and then on an individual basis, that's also how people are determined what coverage they get. And they have to give people a choice of their providers. And we'll talk about what that looks like in a few minutes in California. So in California, Medicaid is called Medi-Cal. In Georgia, it's called Peachtree because there's peaches in Georgia or something. So in Medi-Cal, sometimes our team will say Medicaid and Medi-Cal interchangeably, but they mean the same thing for California. So most of the time we'll say Medi-Cal, but just in case you hear Medicaid, we're talking about the same thing. Medi-Cal covers almost 16 million people in California. We're one of the largest states with the largest population of people on Medi-Cal. It's administered here under the California Department of Healthcare Services. And our program is more expansive than almost every other state. And for two really important reasons. Today on December 15th, Medi-Cal covers people up to age 26 and people 50 years old or over, regardless of their immigration status. It's kind of a big deal. Most states require you to be a US citizen, but California, if you're up to 26 and over 50, that's no longer required. The good news is starting in 2.5 weeks from now on January 1st, that's going to apply to all ages. So anyone 26 to 49 suddenly is going to be covered, and basically from 0 to death, regardless of someone's immigration status, California residents will have access to Medi-Cal. And that's the piece that the state is paying for. So the federal government doesn't require it, but the federal government gave permission to California. If you want to do it and you want to pay for it, go for it. And they did, which is awesome.
Hey, Julie, can I interrupt you for 1 second, just to clarify? Even though it's changing in a couple of weeks, so maybe the confusion might not matter. In case anyone is confused, people aged 27 to 49 can still get Medi-Cal right now. It's just that it does matter what their immigration status is. So these points are just wanting to like give an example of how California is more expansive. So I just did in case that first of all, it was a little confusing for folks. Those age limits we're just kind of make the point about the status piece.
And the truth of the matter, if we're getting into the details, is that everyone's eligible for Medi-Cal, regardless of immigration status. 26 up to 26 and over 50 is eligible for full scope Medi-Cal. And even today, those folks between 27 and 49, they can get limited Medi-Cal. So they're not, they're not limited from accessing it all. It's just what they get isn't what everybody else gets. And starting on January 1st, everybody will have access to the full amount of benefits that are covered under Medi-Cal. So thanks for raising that, Jillian, because it is so nuanced. The other thing that's really special in California is that the Medi-Cal program covers housing related services. So that means, and we'll talk about what that is, but that means if someone is enrolled in a Medi-Cal program, they may have access to the kinds of things that you don't normally think of when you think of healthcare, housing related services. And we're going to go deep into that in a little bit. So here's a brief overview, and you'll see, I'll talk through a few of these. To be eligible for Medi-Cal, you have to be low income, and it's 138% of the federal poverty level or below. That gets updated every year. And so if someone's making $1,000 today and they're not eligible and their income doesn't change next year, on January 1st, they may actually be eligible because the standard of what's the federal poverty level changes every year. Kids are not enrolled in, who are not enrolled in Medi-Cal, over 138% have the special program, the Children's Health Insurance Program, and it's very similar to Medi-Cal, up to 250% of federal poverty level. So when you're working with someone who has a kid and the mom or dad is over, that doesn't necessarily mean the kid might not be eligible for a more expansive program. So it's always important to ask about that. We talked a lot when I did my listing about the type of folks who are eligible. You'll see here a refugee status was made people eligible for Medi-Cal, again, regardless of immigration status, if they were refugees. That's going to change. And that special consideration for refugee status won't matter because everyone's immigration status won't matter. And then, as I said earlier, if you're enrolled in some of the other public benefit programs, CalFresh, CalWorks, often that means you're eligible for Medi-Cal as well, just because those income standards are the same as Medi-Cal or even more strict. And so if you're eligible for those, it's assumed you're also eligible. The other thing is, yeah.
Oh, sorry. I just wanted to say, perhaps you can speak a little bit to how some of these intersect. So for example, plenty of folks have been screened for breast or cervical cancer. It doesn't mean they're all eligible for Medi-Cal. Can you talk a little bit about how these interact with each other?
Yeah, so some of these interact based on your status. So for example, if you're eligible for CalFresh and you're getting food assistance, your income was 100% of poverty, and you'll still have to apply for Medi-Cal for that person. So anyone you have who's enrolled in CalFresh, and you ask them if they have Medi-Cal and they're not sure, it's worth pursuing, because they all should be also, if they're automatically eligible, if they're eligible for CalFresh, they should also be eligible for another program. The income is often the standard. So if you're disabled, the income matters. So if your income is too high and you're disabled, you wouldn't be eligible for Medi-Cal. Is that what you mean, Alyssa? Okay.
Yeah, and just, what it means to be like, who's a parent or caretaker of an age eligible child, but not on Medicaid, or who's screened for breast or cervical cancer, who's not on Medicaid.
Yeah. So what the parent caretaker relative is really important. Let's say I'm over 138% of poverty for myself, but I'm taking care of a seriously disabled child. Then I might be eligible as a caretaker relative. So regardless of my income status. So it's a little bit, it can be a little bit nuanced and complicated. I think our message is, especially with a change in the immigration status, just assume that they likely and might be eligible, especially if they're experiencing homelessness, and investigate, find out, spend the time checking it out. And you'll see this, I think. I'm going to talk a little bit about this later, but most people, I think at least 70% of people experiencing homelessness are likely eligible for Medi-Cal, but it could be even higher. Okay. Managed care is a program that is very ubiquitous in California, so we want to give a little context. The traditional Medicaid delivery system is what we call fee-for-service, and that's kind of like when you think about traditional insurance that we might have. The state contracts directly with providers to offer you services, and then they pay the providers directly for these services. So it's the same way we would contract with an insurance company, and our office would have an insurer, and the insurer would contract with providers and pay the providers when I went to get my arm in a sling, or when I went to go get some kind of a screening. That's the way that Medicaid has traditionally worked. Managed care is becoming more and more common, and it's an alternative to fee-for-service. And what happens in this case is the state contracts with managed care plans, Kaiser Permanente, Anthem Blue Cross, Molina Healthcare, Cal Optima, Partners Healthcare, and they then contract providers to deliver the covered services. The difference is the state pays the managed care plan a per member per month amount, and the managed care plan divvies that up to pay the providers based on services needed. And so what that means is let's just use Kaiser. Kaiser gets paid 100 for me, and Kaiser gets paid 100 for Alyssa and 100 for Sarah. I never go to the doctor that month. Kaiser still gets paid $100 to take care of me, but they don't do anything. They don't use that. Alyssa has surgery that month, and it's a $40,000 surgery. The state still pays Kaiser $100 for Alyssa. And Sarah breaks her arm and she has a $500 service. They still only are paying Kaiser $100. And the idea is the risk is on Kaiser, that it's a mix of people healthy and unhealthy who use the services and don't use the services. They come up with the amount in negotiation with the state, and then they pay providers hoping that they have that amount. They look at their history every year to negotiate the next year and say, we have a mix of people who use the system more, we need a higher rate, et cetera. So it's very different than the way that traditional fee-for-service health insurance. California almost exclusively uses managed care plans for Medi-Cal. Each county has at least one Medi-Cal managed care plan. Some of them have 2 or more. Sacramento has 5. El Dorado has 3. Some plans operate in more than one county. So some of those are the ones that I just mentioned: Molina, Partnership, Anthem, Kaiser. Kaiser now is available in every county in the state of California, but each county has different managed care plans. Just to flag for you all that those managed care plans and which counties they cover is changing and January 1st. And so you might have been hearing the buzz about a plan that your clients and the people you work with have been using for the last 4 years, and suddenly they're leaving that county and a new plan that they're unfamiliar with is coming in. So that is going to be a little bit of a transition happening, and it's going to provide some confusion to people. They will not realize that they likely have a different managed care plan. In most cases, it shouldn't change their access to the actual people who they get direct services for. The idea is that I'm managed care plan 1. Managed care plan 1 covered Alyssa as the physician. Jillian's managed care plan 2, we're switching, but they're still covering, Jillian's managed care plan is still covering Alyssa as the provider. So it should be a smooth transition for some people in terms of who they actually go to see to get their care, but it might not always be. And you might have some experience with that, especially in the first couple months of 2024. The way Medi-Cal works is everyone is enrolled in a fee-for-service in the traditional way we talked, and then they have to pick a plan within 30 days, or they get defaulted into a plan. But if something happens in those first 30 days and they haven't picked a plan, they may go to a provider, and the provider gets paid directly by Medi-Cal. So really important is once they know they're eligible, they should select the plan they want. They want to look, see if their provider is in that plan, if they care about that, and if they have a regular relationship with someone. And then moving forward, once they select that plan, they become a Medi-Cal plan member. So they're an Anthem member or a Molina member or a partnership member. And Molina or Anthem is responsible for providing their health coverage to everyone who is in their plan. So, as I said earlier, 70% or more of people experiencing homelessness are likely eligible for Medi-Cal. That does not mean they're all enrolled in Medi-Cal. So part of what we're going to be talking about today is making sure that everyone who's entitled to health coverage gets it. You can find out a number of different ways whether your client has Medi-Cal. If you work in HMIS, they may have a copy of the Medi-Cal card uploaded in HMIS. If you work in HMIS and you don't see a card, but you work with your client and you know they have a card and you want to take a picture of it and put it in HMIS, that would be awesome. Take a picture of both sides, because that way we can find out. It helps the CE system and it helps the homeless system of care know who their plan is, what their contact information is, what the plan number is, and that really will help you as well, so that when you pick up a new client, if someone's done that well, you can see who their plan is. You'll be able to find their Medi-Cal number and help them access care faster. Referenced in that was ask your client if they have a Medi-Cal card, and it should have their number on it, and it usually says which plan they're enrolled in. And again, if you could take a picture and upload it into HMIS, even 100% better. If they don't know if they have Medi-Cal, they don't know have a card, but you ask them, do you have a managed care plan? If you know which the managed care plans are in that county, you can ask them by name. Oh, have you heard of Anthem? Have you heard of Kaiser? You can ask them you only need 5 names total if you're in Sacramento, but in most counties, you only need to know 1 or 2. You can just share what that is and see if those names sound familiar to them. And then you can call the client's county Medi-Cal office and find out. You can also sit with your client and look online. Everyone has the ability to enroll in the online account, and you can, if they have Medi-Cal already, they can set up an online account, and that will tell you if they have who their provider is, who their managed care plan is, what their Medi-Cal number is, etc. And if you can't find them in there when they sign up, then you can help them apply for coverage. So online is a great way, and I think later we will have links to that. Just to say, we're going to send this PowerPoint out with active hyperlinks to any of the things we're referring to, so you'll be able to click on them and go to all the resources that we share as we move forward. Why this information matters. First of all, you want to make sure everyone's covered. I strongly believe that more than 70% of people experiencing homelessness are eligible. And if you all do the work to make sure everyone who's eligible is enrolled, we're going to show that number is a lot higher. we need to show that number is a lot higher because without healthcare coverage, they don't have access to healthcare services. And we need to find that out. If you can find out of the name of the managed care plan and their Medi-Cal information, you can help them access healthcare. Really important, obviously. You can refer them to benefits that are covered under Medi-Cal. We talked a little bit that there are some new really special housing related benefits under Medi-Cal. And if they have Medi-Cal, they are likely eligible for those housing related benefits. And Alyssa's going to talk a lot about those in just a few minutes. So that's really important. Again, if they don't have Medi-Cal, let's get them Medi-Cal. Let's get them the health coverage they need. If they're over income for Medi-Cal, don't stop the conversation. There is another program called Covered California, which offers similar services, similar coverage, and subsidies to pay a premium so that it's very low cost healthcare. It's not free and it's not an entitlement like Medi-Cal, but it's still really important. And many, many people just above the Medi-Cal eligibility can pay it, can get coverage with little to zero premiums and very low out-of-pocket costs. So it's hugely worth it to investigate that. So don't stop if you're applying and it seems like they're not eligible for Medi-Cal because of income. And also really important to know about Medi-Cal so that they don't lose their Medi-Cal coverage every year. They have to show the state and tell the county, I'm still eligible. My income hasn't changed. My family size hasn't changed. And Alyssa will also talk a little bit about that and why that's important. So just sort of going through some of the resources to get access to services. They have to be enrolled in Medi-Cal. They have to choose a managed care plan. They should choose a managed care plan to access all these benefits. If they're not enrolled, the online system for everyone across the state is benefitscal.com. And if they may already have it, you can help them register at benefitscal.com to see what their managed care plan is, what their number is, when their benefits are up and they have to renew, all those kind of good things. If you feel unequipped to help someone apply, there are free enrollment counselors who can help your clients. So one of the things we really like to talk to street outreach and encampment case managers is find out who your enrollment counselors are in your community and work with them. They get paid to do this. So maybe have them join you on an encampment visit and do an enrollment fair, just like come with you and sign up, you know, the 10 people at the encampment who might not already have Medi-Cal, or they can go with you and help to figure out who's up for renewal and help them renew. So you don't have to do this all yourself. Again, if you don't choose a plan within 30 days, they'll choose one for you. And it's really important. And Alyssa will talk about this. So I'll leave it here, is that you have to submit referrals or application form to get these housing related services. I'm going to stop and breathe. Make sure we have any questions before we pass it on to Alyssa. Any basic questions about Medi-Cal, feel free to raise your hand, put it in the chat. Jillian, any questions in the chat?
No, we don't have any in the chat. So if anyone does have questions that you've been holding, feel free to put them in the chat now. Or like Julie said, you can use the hand raise or just come off mute. No one's talking right now. So if you want to come off mute and ask a question, feel free.
I'm psyched that you all understand it. And like I said, this was basic and you probably got a lot of this already, but we wanted to make sure everyone on the call had it for the context for then the next conversation. So I'll go ahead and pass it to Alyssa.
Thanks, Julie. Hi, everyone. Great to see this crowd. And I'll just say, you know, like in any field, I think this one has a lot of jargon, a lot of acronyms. So really just want to encourage people. I know we've all been saying it, but really do feel free to say like, what is that? Why is that? What are you talking about? And yeah, it can be a lot. So Julie has mentioned a few times these new housing related services, things that are kind of unique about California's Medicaid program. So we're going to dig in and I imagine a lot of you have heard about CalAIM, maybe have heard some of these words, and we're going to just dig in on what that is. So I think I wanted to set the kind of national context a little bit to say that I think the healthcare delivery field is in the middle of a shift, with a lot of kind of providers and people really understanding that to address a lot of healthcare conditions, you have to address an individual's broader life conditions. And so, the term social drivers of health, social determinants of health, health-related social needs, those are words that are coming up a lot more because there's an understanding that, if somebody goes to the emergency room or the doctor's office and gets a medication, and that medication needs to be refrigerated, but they live on the streets or they don't have money to pay their utility bills and don't have refrigeration, how are they going to take that medication, and how will that medication then help, control their condition? It can't, right? So I think there's this sort of growing understanding, again, across the country that healthcare has to really grapple with these broader kind of social issues. And so you're seeing, I think, a transformation in a lot of different kind of healthcare delivery systems, but particularly in Medicaid, to begin to address things like food, like housing, like transportation. And California is very much at the forefront of a lot of that work. And CalAIM is very much a part of that work. So I just wanted to sort of set that context. So CalAIM, if you can go to the next slide, Julie, CalAIM, which stands for California Advancing and Innovating Medi-Cal, is a new-ish Medi-Cal initiative. You may hear folks say an 1115 waiver. Those are waivers that states apply to the federal government to say, we want to do things differently. We want to try, some innovative solutions. And this one is called CalAIM. So it's really focused on improving the health of Californians with the most complex needs, and started in 2022. And it does a lot of things. And we're not going to cover all the things it does. It addresses behavioral health expansions and criminal legal system transitions, and a lot of things. And we are really going to focus on what it means for people experiencing homelessness with complex conditions, who are one of the populations of focus, and some of these housing related services. Next slide, please. So we'll dig in on each of these, but the two programs that are most relevant for people experiencing homelessness or risk of homelessness are Enhanced Care Management, known as ECM, and Community Supports. I think the thing to know here is that every managed care plan has to provide ECM to their eligible members. It's not a choice, whereas Community Supports, those managed care plans are encouraged but not required to provide specific community supports. So what that looks like varies by county, by MCP. So it's a little bit different. And the reason why is a function of, without getting too deep into it, it's a function of kind of how the federal government sort of allows and kind of pays and lets the MCP sort of pay for those services. So so that's kind of the underlying reason. So just know ECM required, community supports really great, encouraged, not required, but still is definitely still happening across most communities, and more can get added over time. Next slide. So we'll dig in on these in detail. So enhanced care management. So individuals and families experiencing homelessness are eligible for ECM. And I think the point of ECM, which all of you will know from your work, is that it recognizes that people with complex conditions rarely need to just tackle one issue in order to be healthy, right? They have issues with housing, maybe mental health, food insecurity, substance abuse challenges, accessing services because they don't have transportation. And we know it is hard enough to navigate one system or one set of appointments, let alone many at the same time. And so ECM is intended to provide people with that sort of comprehensive coordination service. So ECM care managers help Medi-Cal members set clear goals, make sure they receive sort of the full array of benefits and services they're eligible for, and coordinate across systems. I think that is important in and of itself, but I think one of the things that's really unique is that ECM providers are required to meet members where they are. So it's not just saying, come to our clinic, come to the four walls of our doctor's office to get this service. It's saying, we will come to where you are, whether that's at the shelter, on the street, at home. So it really sort of breaks open kind of what is possible for receiving these services. And so, you could imagine an individual whose case manager meets with them at a shelter, brings them an application material for CalFresh or other services, benefits, helps them, kind of make a doctor's appointment, helps them arrange transportation to that doctor's appointment, helps connect them to a community support. So really playing sort of like air traffic control for all the things going on in their life. Next slide, please. So this is what's known as community support. So these are these new services that managed care plans can add to the packages of services that they offer. It's for members with complex health needs and unmet social needs. And so if you look through this list of 14 community supports, what strikes me and probably all of you is that anyone experiencing many people experiencing homelessness who are unhoused would probably benefit from a lot of these services, right? So, medically tailored meals or, any number of sobering centers, any number of things, but there are 4 that are explicitly connected to these housing services. So they're really important because they're services that, a COC might be provided through COC providers. But instead are being paid for and provided through Medi-Cal. So that's really unique. So we have housing transition navigation services, housing tenancy and sustaining services, housing deposits, and short-term post-hospitalization housing. We'll share in a second in our presentation some materials that Homebase has created that really digs into each of those 4 in detail of like what exactly does that entail and how is somebody eligible. So we're not going to go into that next layer, but just know we have resources if you're like, well, what does that really mean and how would my client get that? We have those materials to provide that information. So again, just really unique set of services that you don't, as Julie said earlier, you don't typically think of Medi-Cal or Medicaid or health insurance program as providing housing deposits, for example, and we are lucky enough to have this program. Next slide, please. So the community support referral process. People who are eligible for ECM and CS can be referred by anyone. So it can be self-referred, community members, providers, or others. Folks have to be enrolled in Medi-Cal. They have to have an MCP and be eligible. And again, that eligibility criteria looks a little bit different depending on the program and the particular community support. Once somebody is approved and enrolled, the way that works, so managed care plans contract with different providers for ECM and community support. Some are right in the community, some have experience working with people experiencing homelessness, some do not. So that's, we're looking at that across the state and we can talk about that in more detail. Members who are receiving both ECM and a community support may or may not have the same provider for both, which, can maybe a little tricky, but that's just a reality of where we are right now. And if they are enrolled in ECM, then that provider can and should assess and refer them to appropriate community support. So I just want to hit pause a little bit and say that what we are seeing in our work with communities and folks who are kind of really focused on the rollout of these programs is some confusion about, who are my ECM and CS providers? Who's doing this work in my community? How do we refer people? How do we access these services? So I just want to say these are amazing services. And as I mentioned, this whole transformation was initiated. There were some, kind of predecessor preceding programs, but this was initiated in 2022. This is a whole new way for the healthcare system to engage, for it to engage with these populations, for it to engage with people experiencing homelessness. And so there are things that are still shaking out, right? And so we are seeing that, we're hearing that. And, what I would say is if you have questions about like, how do I find out what that list looks like in my community, talk to folks from your COC, talk to, see if there's somebody focused on health from your COC, see if you have relationships with your managed care plans, who they're contracting with. So there are resources to sort of find and access, and also there are going to be bumps in the road as you try to find that. I just want to hit pause and see Jillian and Julie if there's anything you want to add to that.
Yeah, what I was going to say, the only thing I was going to say is we should, we'll put our email into the chat, because we can tell you what, if it's not easy, which plans are in your area. Or we can point out, I can't remember if we put the Medi-Cal directory in here, but because they're transitioning, they're updating that. But you can reach out to us if you need to figure that out.
Thanks, Julie. Okay, next slide, please. Oh, okay. So here are the resources. As I mentioned, Homebase has put a lot of time into creating some kind of primer resources, and these will all be available for you. They're on our website, and we'll send this out so you can dig in with all your copious free time. So next up, we want to talk about this really unique moment in time. We've spent a lot of time talking about, Medi-Cal, what it offers, the benefits it offers, the unique benefits it offers right now with all these housing related services. But there is kind of this national wave of that we're going through this period of renewals where everyone has to renew. And we want to talk about how you prevent people from losing this very valuable coverage. Next slide, please. So what if we'd like you to imagine that your access to healthcare was dependent on receiving a piece of mail and you didn't have a stable mailing address, which obviously is the case for folks in many, if not all, but many folks living in encampments. So this is really the crux of the issue that we're going to talk about, the challenge that this period of renewals is posing for people experiencing homelessness and folks who are unstably housed. So just to give some background, Medi-Cal enrollees and anyone receiving Medicaid throughout the country has to enroll their coverage annually. The process is where the county determines if somebody is still eligible to receive their Medicaid. And during COVID, there was a 3-year pause in renewals. And at the same time, a lot of new folks came on the rolls. The renewal process restarted in California this June. It started again across the country this spring, between sort of like April and June. And as a result, people are expecting that 2 to 3 million people will likely lose their Medi-Cal coverage throughout this year-long renewal process. And that includes roughly 1.5 million people who are still eligible. And so you'll say, like, well, what's the difference why is there a difference in those numbers? And that's because some people who maybe got Medi-Cal before COVID or during COVID, maybe they've gotten new jobs and they're no longer income eligible, or some of the other categories that led them to be eligible is not the case anymore, and they don't need Medi-Cal anymore. Maybe they have employer-sponsored healthcare at this point. But there are going to be 1.5 million people, maybe more, maybe less, but probably more people who are still eligible, but through this process of having to kind of renew their coverage, they're going to lose their Medi-Cal due to what's known typically as like procedural reasons. Maybe they didn't get the form in time. Maybe they got the form and it was really confusing, or it wasn't in their language, or they sent it in, but their backlogs at the county and they're not processed in time, or a million other things. And those folks may have their Medi-Cal terminated, even if they're still eligible to receive it. People experiencing homelessness are particularly at risk of losing coverage. And that's because so much of the outreach effort around renewing happens through the mail, and a lot of that mail is sent to last known addresses. And we know that's a huge problem for people experiencing homelessness who are moving around and not in a stable place to receive mail. So that's, Homebase saw this issue and really wanted to come together and create a campaign to try to address this. I also just wanted to note, you may hear renewal, you may hear redetermination, you may hear recertification. Those things are all the same and are all used interchangeably. Next slide, please. So the process, just to go through quickly, everyone has a different renewal date. It's going to be 12 months after they enrolled or renewed, or some, multiple of 12 if it happened before COVID and they didn't have to renew. renewals can happen two different ways. One way is automatic. Every state has to try to renew a member's coverage using information they already have, electronic data sources that the state or county has access to. And in that case, the individual doesn't have to do anything. They just get a letter saying that they've been renewed. The other way is manual. And so if Medi-Cal can't automatically renew somebody, members get this yellow renewal packet, again, in the mail, and they have to return that packet and share information, whether it's, income information, change in circumstance, within about 2 months. Next slide, please. So the state has done a lot to try to streamline what they know is a challenging process that will lead to a lot of people losing Medi-Cal unnecessarily. And they have pursued some special kind of waivers and rules that are particularly useful to simplify the renewal process for people experiencing homelessness. So one is if an individual is very low income, has fixed income, or has $0 income, so 100% FPL or below, they may not need to complete a renewal packet and their renewal will happen automatically. The second is if the county knows that an individual is experiencing homelessness, they may be able to extend somebody's timeline and renewal out, but this requires that the individual sort of share that they are experiencing homelessness. So one is just, automatic, and one requires more kind of proactive communication. And there are some ways that we've suggested that providers help clients prepare to renew. So find out, again, Julie covered this earlier, how to find out if your client is on Medi-Cal, and in that process, try to see what their renewal date is. So again, you could ask your client or check HMIS for a copy of their Medi-Cal card, call the county Medi-Cal office to find out, what are they enrolled and maybe what that timeline is. Identifying mailing options and help clients update contact information. So even if somebody is unsheltered, living in encampments, are there providers or organizations in your community that are sort of accepting mail on clients' behalf? That can be really valuable. And then you can use that updated mailing address to update, share updated contact information with the county. Julie already talked about this. We really say, you are already expert in serving people living in encampments, and Medi-Cal is a whole deep thing that, often requires expertise, and you can forge relationships with people whose job it is to do that sort of outreach and education and enrollment and helping people apply every day. So we really encourage folks to connect with health enrollment navigators, and forge those kind of partnerships. We have links to the different health enrollment navigators in each county. Try to find out if you think your clients are eligible for auto enrollment. Highly likely, they are highly likely eligible for those auto enrollment options, and advocate, with the county for auto renewal if it seems like it's not happening. And then for those who are going to have to do the manual process, see if you can help them access personal documents and information which they will need in a manual application process. Next slide, please.
Alyssa, I just want to add one point to the calling the county. If you're calling the county on behalf of your client, they won't share information about your client with you unless you have your client on the phone with you. So you can do it together. You can do a three-way call. There are some situations where you can become an authorized representative of your client, but that's kind of complicated and not necessary for these short calls. It's just making sure your client's with you when you do that outreach, because the county will not share information without the client's permission.
Thanks, Julie. And I would also say, the reality is that these systems are stretched. And so just, want to share that we've heard stories, of trying to call the county, and we know it can be an hour, over an hour to wait. So if you look, you'll see we created a toolkit that goes into all of this in a lot more detail, and we provide different ways of sort of helping, different ways of helping folks apply, renew. Some of it might be, through the mail, some of it might be online, some of it might be calling the county, going in person to the county, and different options are going to work for different people and different communities. And so we gave all the options. And so just wanted to share some of the kind of realities associated with those different options. So again, just a few more resources that you'll be able to access easily once we send this out. So that concludes my portion. Any questions that folks have? Again, we covered a lot between CalAIM, renewals, ECM, CS, anything there. Eric, please.
Hi, good morning. I'm Eric Batista with KCHA. I'm a street medicine housing navigator. This is a new program that we are doing in the community, and we are going to the encampment. My question is for Julie. For the county, when we call, even if we have the ROI, they still not going to provide that information?
Yeah, your ROI isn't the county's ROI.
Okay.
They
Yeah.
have told the county that you can talk to them on their behalf, where your ROI is probably more homeless system of care ROI.
Yeah.
So the county you can become an authorized representative, but if you're with them and just call while you're with them on the street, that's probably the best thing to do.
Okay.
So help them sign up. We didn't talk a little about this, but it's in our materials about online. You could find out a lot of this stuff online, and there's
Okay.
when you're renewing, there's a primary question like the third screen: are you experiencing homelessness? So it might be more efficient before you try to call to see if you can do it online with your client.
Okay. Thank you so much.
Any other questions? And so part of why we went into this Medi-Cal renewal process in so much detail is, again, because these are incredibly valuable services that folks can now access through Medi-Cal that are really powerful for people experiencing homelessness. And so what we don't want is for people to have this service and access to all these incredible housing services, and then through this renewal process sort of lose access to all these additional benefits and services.
And I want to say one thing. We talked a little bit about Medi-Cal. Medi-Cal is an entitlement. That means no matter how many people want it, if they're eligible, they get it, regardless of how much money it's going to cost to the state and to the federal government. We know working in homeless system, it's a limited resource. It's not an entitlement. So if you don't have enough housing navigators in your homeless system of care to help create a housing navigation plan, and they're a Medi-Cal eligible member of a managed care plan, they might be able to pay for a housing navigator and housing navigation plan that you otherwise couldn't do in the homeless system of care, because you're limited to what's available, and Medi-Cal is an entitlement. So that's really important to remember, to try to maximize the health system paying for some of the stuff to free you up as a homeless system of care, and you as a provider to be able to do the things for people who wouldn't otherwise be eligible. So just want to say that.
With that, unless there are other questions, you can turn it over to Jillian.
Thanks, Alyssa. Thanks, Julie. Hi, everybody. I get to cover the more fun, interesting stuff, I think. And that was all very important. And I'm very glad that it's information that you all are getting, but I feel like I got lucky with the portion that my colleagues let me present. So I'm happy to talk to you about, now that you know a bit more about how to make sure that the folks you're working with in encampments are insured and stay insured. Excuse me. Especially because we have these like very specific housing related resources that are new and we want people to be able to get access to. I'm going to talk a little bit about connecting, how to make sure we're actually like connecting folks to healthcare in encampments, because you can have great insurance and be enrolled in great programs, but that doesn't mean it's that easy to actually like get service. So that's what this next section's about. So I'm going to cover a couple things. The main thing I'm going to go over is actually trying to make sure you're getting the folks that you're working with in encampments care like to them. And then also the other piece I'll mention is just some tips on how to like find out who the local healthcare providers and resources are in your local community. So the first thing I want to talk about, so Eric asking the question was a great segue into here, because I got very excited when he mentioned he was part of a street medicine program, because that's the first thing we want to talk about. Street medicine, that term is used to mean different things. So I'm going to talk a little bit about sort of like formal formal street medicine as it's kind of defined in California, but I'll have another slide where I talk a little bit about things that sort of look like street medicine. You might hear street medicine referred to as backpack medicine or other kind of phrases like that. But essentially the idea is, it is kind of what it sounds like. It is medicine, or it is medical care that is delivered to people on the street, like exactly where they're residing. So it's care that's getting to people, especially in unsheltered locations, including encampments. And the idea is that the medical providers, healthcare providers, are actually going directly to people outdoors in their cars and their trailers if they're in tents, or elsewhere outside in encampments, or just on the street anywhere. The medical care is actually going to them. The providers are meeting with people exactly where they are. It includes the actual delivery of healthcare services on site, so that someone doesn't need to go to a clinic or go to a hospital. They don't have to leave where they live or where they're staying in order to get care. And so in addition to actually, so it basically looks like, it's a little bit, I think one way to think about it is it's like street outreach, but there is a medical care component to it, right? So the idea is you are having folks who actually are healthcare providers being able to like provide that care, whether that's wound care is a lot of it, or you can maybe provide some, depending on the program, and you can actually like deliver medicine to people where they are. You can kind of take care of issues that are safe to take care of on the street, so that folks don't have to go anywhere else. However, there also is a component where as you're coming into contact with folks who are living on the street and helping them with their medical needs to the extent that you can then and there where they are, they also very well could be a need for additional medical care that kind of would need to happen either on an ongoing basis or something that's not really safe to do outside, and so would require sort of more traditional medical care. So street medicine programs are also meant to help, probably over time, connect the people that they're providing care to a more ongoing primary care provider or other medical services that are maybe more in traditional settings. So it's both the provision of healthcare on the spot wherever people are, and also an attempt to connect folks to additional care kind of on a more ongoing basis as they're able to do that. There are ideally street medicine programs are also, because the folks who are providing care are building relationships with folks, they're also hopefully able to connect folks to other resources in the community, right? So if someone is interacting with folks in encampments, for example, providing care on an ongoing basis and getting to know someone, hopefully they're also aware of housing resources that are available in the community and can also help to connect folks to housing and other resources. So I know now that I know there's at least one person on here that is on a street medicine program, I would welcome, if I don't know if Eric or anyone else wants to share anything else, I'd welcome anyone who wants to share more, either now or kind of when we get to Q&A. But street medicine programs are hugely exciting. I love talking about street medicine, and I love that street medicine exists for lots of reasons, including because it is providing a very vital service to people who otherwise would not be able to get it. And in addition to that, which is just a great outcome on its own, it's also a really great way to, as this last bullet says, to really build real trusting, meaningful relationships with folks. And part of that is because if you think about a lot of outreach programs are limited in what you can actually connect people to, just because, as Julie said, in the homeless response system, there are limited resources, unfortunately, right? There is such a difference between the amount of need there is in every community and the amount of resources available. And so a lot of times, even the best outreach programs and the best outreach workers, you're limited in what you can offer someone, especially on the spot, because sometimes the resources just aren't there, right? And so a lot of times, as I'm sure a lot of you know or are finding, it can be really frustrating and disheartening, to say the least, to people who are kind of interacted with and talking to folks on a regular basis and asking for help, and that help is just not available at all or yet. And so that can be really difficult to kind of build trusting relationships when you're not able to deliver the things that you want to be able to deliver them. With street medicine programs, there is an immediate sort of meeting of a very crucial need, right? So that can really help build those relationships, because someone is being helped on the spot in a really real way, and that can really go a long way to building those relationships. So street medicine programs, big fan of street medicine programs. I love talking about them, so I hope people have lots of questions, or maybe you're all connected to street medicine programs, and that would be amazing too.
Good morning.
Yeah.
I started in November with the street medicine program, and we go with a group of doctors, and we basically go around their schedule. If they want to go next week on a Monday in the afternoon from 1 to 4, we work around their schedule. And sometimes we go with 10, 8 doctors that are going to be on the site and the encampment. And it's so wonderful to see all these people. They're recognizing because we go with the medical street band, so they're recognized already. They sign the paper, and like Jillian said, they're not only there for services for medical, they also, if they need housing, I'll step in as well and do the BS Bedai to get them housed and getting connected with the services. I'm so happy that I'm working with the street medicine because I'm able to provide a lot of resources for the client. And also, this is preventing them from being going so many times to the emergency rooms, and they having a connection. They do follow up. And like Jillian said, if they need other procedure, they schedule an appointment and they do the follow up. And we also provide transportation to take them to the KTHA, they do provide the transportation to take them to the medical appointments. And also, we go and pick up the medication because we get the prescription, then we take it back to the MCAM, and the medication is distributed, and we do a lot of follow-up. So the project is a great project that we are doing. And like I said, I'm very excited to continue this project and getting them connected. The doctors are very down to earth, they have empathy for the clients that I've been seeing, and the people are getting connected with them. They are opening, when you are engaged, getting all the information, they tell you, maybe they go for one thing, maybe they have like a little cough, and then when you start talking to them, there's so many things that they need. And we could, and it could be their birth certificate, it could be their ID, and we getting connected with the vouchers right there. Everything is done right there, and we do the follow-up. So we've been doing this. Like I said, I started in November 16. I've been going with Ana Lopez, that she's house at Career Delta. She actually the coordinator. So I work under her, and we go everywhere. So she sent me the information where we're gonna go, to the encampment, other location, to the warehouse ministry, and we do the outreach there with the doctors. We always have all the doctors on the side helping our clients.
That's all. Thank you so much, Eric. I knew I was right to be excited that you were on the call in front of the street medicine program. Really appreciate you sharing the specifics of your program, which sounds amazing. It also is a helpful reminder that I did want to say that even though there is now a sort of official definition of street medicine as it's able to be reimbursed by Medi-Cal in California, we're not going to go into that in detail. There are still programs that will refer to themselves as street medicine programs, street health programs, backpack medicine programs, that sort of thing. That they all look different, right? It's there are different kinds of programs. So the program that Eric is describing might be similar to what you have in your community if you're not in the same community as Eric, but it also might be different. So there are street medicine programs that, and we have a link in the slides too, where to this quite long sort of paper where you can learn about at least some programs in California if you're curious to find your own, and also just to learn more about them. There are programs that are set up such that it is truly outreach with medical providers, right? So it's sort of canvassing areas, and maybe you're covering the entire geography of your community, or maybe you cover a certain part, maybe you go to a particular encampment. And it's sort of whoever you come in contact with, you're asking if they need anything, including healthcare, and kind of providing it as needed as you can. There are programs that do that, and also do kind of what's like doing rounds at a hospital, where they have a sort of patient caseload of people that they interact with, and if they continue to need care, then they'll continue to go back out. Maybe their rounds are every Tuesday at 9 a.m., right? And that the group goes out at that time. And kind of connects with the patients they've already seen, and also probably interacts with new people to see if they need help, and kind of adds to their patient list. There are folks, kind of depending on how big the team is, how much capacity there is, there are programs that can also do very specific sort of in addition to just kind of rounds, right, at a regular time of day. They might be have a big enough team, or sort of be a big enough program where they can schedule individual follow-ups with people, they know this person can't be around for the normal rounding time, and so they'll make a special visit to that person, right, as follow-up. So it really depends on the program or programs that you have locally, how they're set up, how many people, what kind of providers are on the team, and sort of what their schedules are, and where they go and who they interact with. But regardless of sort of exactly what it looks like, the sort of basic premise that, you know, we've been talking about and that Eric shared, that is just so important for getting folks like medical care exactly where they are in encampments is really the kind of thing we really want to like focus on or emphasize at least. Jill, you can go to the next one. Thanks. So this is just like a just so folks know, this slide is basically covering some things to let folks know, or maybe like be reassured that we're hoping that there have been some recent changes lately that will hopefully allow more street medicine programs to either pop up or expand. It's basically that the state and the federal government has made it a bit easier for providers to, for example, bill Medicaid for street medicine and therefore get paid to fund those programs. So it used to in a couple different ways. So street medicine used to be that you could only have a street medicine program if it was connected in some way to an existing like brick and mortar standing clinic or a hospital. But starting at the end of last year, street medicine providers can actually bill Medi-Cal, so they can kind of fund their programs even if they're not part of connected to a brick and mortar. So again, just kind of wanting to let you all know that there might be newer programs or more programs coming up because for that reason, and also some like Medi-Cal billing code reasons that you don't necessarily need to know unless you're the person that's having to do that, have basically just made it easier for programs to get funded because they can bill Medi-Cal easier. So this is mostly just good news we wanted to share, unless Julie or Alyssa, if you wanted to share anything else on this. Just wanted to like at least make people aware that there might be some more programs or newly expanded ones. The last, I did want to mention just quickly, ECM, Alyssa talked a lot about ECM. And so this last bullet where it says ECM can be a great resource for a street medicine program. So if I know this, we're not trying to via this training, like convince you all that you need to start your own street medicine programs, right? We just want you to know that this might be a resource in your community. But ECM, that enhanced care management benefit, can be like a person who's an enhanced care manager could be part of a street medicine team, which could be really great. So that's something to kind of just think about. And there's also something called a community health worker. It's regardless of whether it's paid for by Medi-Cal, that folks might have, like be familiar with the phrase community health worker, or sometimes they're referred to by different job titles like promotores or community health representatives or health navigators. But they're essentially folks who are not necessarily licensed healthcare workers, so not necessarily like nurses or doctors, but they're folks who can provide some sort of health related services in a community. And there is a newish Medi-Cal benefit for community health workers. So again, just kind of something to be aware of, that this might be a resource that's available in your community. And these folks can provide basically services for anyone who has like one or more chronic health conditions and some other conditions as well, could be eligible to sort of receive services from a community health worker. So lots of folks you're working with in encampments might be people who could benefit from these services. And so it could be that these are really good sort of like people who are working on street medicine programs or other kind of similar programs to kind of help supplement the actual like traditional medical care and provide a lot of other services that can be really helpful for the folks you're working with. So as I mentioned, street medicine includes like a very formal definition of what it is. And so we also want to just make sure you're aware of other kinds of sort of like similar healthcare programs that are not quite technically street medicine, but are intended to serve very similar purposes. So Eric, I think Eric mentioned like a mobile van that they use as well. So there are things called mobile clinics or mobile medicine programs, which might not be technically like backpack medicine because it might not include people literally going out into like to someone's tent, for example. But the idea is similar, right? It's intended to bring medical care closer to where someone lives, as opposed to having someone have to come into a medical building like a clinic or a hospital or anything like that. So it's still the idea is still we're bringing medical care to people right where they are. The main differences are likely the mobile clinic is like in a van, for example, and sort of what it's equipped with might vary a lot based on the program. So it might like you could walk into some of these that are in these kind of trailers that look like a little mini doctor's office, like they have all the kinds of things. Some of them even have like a little mini ultrasound machine, like they have lots of different equipment, kind of varies depending on program. But so the main difference between sort of mobile clinic or a mobile van and more tradition and more like backpack medicine or street medicine, is that someone is likely going to have to like literally leave either their tent or where they stay and go a little bit of a distance, maybe just to the edge of the encampment, for example, or the closest area where the van was able to park, for example. So it requires someone to like leave their exact location. So just keeping in mind that might mean that they have to leave their belongings, right? So it's like a little bit different. It's a little bit putting a little bit more on the person, but still a really great way to get care to people in encampments and other unsheltered environments. And it might be that some mobile programs, it sounds like maybe this is like Eric's, some mobile vans will kind of like drive as close as they can get to an encampment and can see people in the van, but also might like walk away from the van to actually like visit folks where they are, right? And if necessary, like if someone needs more than basic wound care, for example, they might kind of accompany them back to the mobile clinic to actually like provide a little bit more care. So again, it's sort of like everything, right? Every resource in this space where different programs look different. But again, want you to be aware, especially if you're going to try to after this training, go try to Google like in your county, are there street medicine programs? Are there mobile clinic? We just want to give you all the words that you might need in order to kind of like look around to see what's in your specific community. I do just want to note that, you know, I've mentioned wound care a couple of times, that it is that's like one of the more common things that street medicine and mobile medicine programs offer to folks. It's a more common sort of healthcare delivery that happens on the streets. But there are, as well as like over the counter or kind of basic medication that folks might need. But there are street and mobile medicine programs that can include a lot more, right? There are some that actually have psychiatrists or other mental health professionals or substance use treatment professionals that are part of the team, either like on an ongoing basis, or they can kind of bring someone out if they need to, if someone needs that. So there are more like expansive, sort of robust treatment options that happen in street medicine programs, just depending on kind of how that program is set up and how it's staffed and who's available to be part of it. Even if your community, if you go off to this training and you look and you either don't have a street medicine program or a mobile health program in your community, or you just can't find it, or maybe it's the way that it operates is limited in a way that you're not able to get your folks that you're working with connected to it. There are other things you can kind of think about trying out to bring medical care to your clients that are staying in encampments. So one great thing that's sort of like short of an official street medicine program is just you can invite different kinds of healthcare professionals to come out with you as you do outreach on your teams. Either just to accompany you to kind of like start to get to know people, to sort of like see the conditions that folks are living in and better understand what the health needs are, and not just the health needs, but sort of like what kinds of treatments and care will actually work for someone. So even if someone sees someone in a hospital, right? If the hospital healthcare provider is recommending that they do X, Y, or Z to get better, sometimes they don't really understand the realities of where people are living and like which of those things are actually possible to do, right? So I think even if someone's not going to be from the outset able to deliver care with, like if they come out with you, it's also a really great way to sort of just like help healthcare providers who are interested in working with this population better understand like what the realities are of the folks living in encampments, so they can better figure out ways to help provide them care. So if you're thinking about kind of reaching out to or connecting with healthcare providers in your community to sort of invite them to consider coming out on outreach, we would just want to encourage you to think that it as broadly as possible about healthcare workers. So I mentioned community health workers and enhanced care managers. Those can be really great folks who are already, like their entire role includes helping people experiencing homelessness, right? And their jobs include going out to where people are. So that's a really great resource for this sort of strategy. But also local medical or nursing schools or teaching hospitals might be really interested in creating programs for the folks who are kind of in training still. It's not just about, you know, MDs or medical doctors. There's lots of different kinds of nurses, nurse practitioners, and other healthcare workers, physicians assistants, who might be really great options for kind of building relationships with and connecting to your folks that you're working with in encampments.
Julian, I was going to just chime in with a story.
Yeah. Great.
So in that community, the local hospital had hired a nurse practitioner to be the primary contact and provide healthcare services, you know, limited to people experiencing homelessness, but she was a single person. And so she went to the library where a lot of people congregated, and she went to a safe parking site where other people congregated, but she wasn't really comfortable going by herself to an encampment. So we introduced her to the street outreach team and said, you don't have to go alone, because she wasn't familiar with working with people experiencing homelessness. And so she then started partnering with the street outreach team. And when they went out, she would go with them, and she would do the same thing she was doing at the library, but she was actually doing it at the encampment when she wasn't comfortable doing that just as an individual going on her own with that experience. So that really has changed the community a lot because of that, because they now have, limited, but they have someone there doing wound care and then providing some advice.
Thanks, Julie. If anyone else on the call has a similar story or wants to share anything, please feel free. In addition to, I know we've been asking if you have questions, but obviously if you have anything to share, we'd love for you to be able to share with everyone else on the call too. Okay, Julie, I think you can go to the next slide. So we wanted to also just share a couple of some additional strategies for helping to connect folks that you're working with in encampments to care, in addition to like care that comes literally to them. So a couple of things that we've seen work in other communities that you might that you can think about considering if you're not already doing some of these is you can work with local healthcare providers, either at hospitals or in a couple of minutes, I'm going to get to some slides that kind of list out different kinds of providers that might be good for this. So I'll get to like what kinds of providers, but they might be willing and able to set aside like specific days or specific blocks of time where your clients, maybe encampment residents, can sort of walk in without appointments. We know a big barrier to accessing healthcare is just it's difficult for people that are living in encampments to make and keep appointments, right? For like transportation reasons, for all lots of different reasons, right? So if there is some time that a local clinic or local provider can set aside where they allow walk-ins, whether it's just for folks in your program or that you're working with, or kind of more expansive for folks experiencing homelessness, that can be a really great way to get folks connected to care if there's not, a street medicine or similar program locally that can connect to your folks. Just a note, like as with anything where folks are having to get somewhere, right, that might require some transportation support, and also some ways for people to feel like they can safely leave either their belongings, their pets if they have them, that kind of thing. So obviously it's not as simple as just, great, we have this block of time for you, go connect to this clinic, but it can be really helpful to reduce at least one very common barrier to folks getting to actually go see doctors. If we're thinking about like prescriptions and medical care, there may be some local pharmacies, either kind of like corporate pharmacies, even like Walgreens or CVS, or other sort of smaller pharmacy programs, or pharmacies out of hospitals, for example. If Kaiser's operating in a community, maybe one of those pharmacies. If you can kind of like build relationships with some pharmacists to try to help figure out a way to simplify the process. So sometimes this happens through street medicine programs where they have relationships with pharmacies where they're able to kind of like make the process to fill prescriptions, or kind of like they have an agreement where I as a street medicine provider can go pick up a prescription for a person, right, as opposed to them having to go pick it up, that kind of thing. So there can be ways for you to kind of talk through and think through with a pharmacy partner, a way to like just make it easier for folks that need medications to actually get the prescriptions filled and to get the access to them. And then a really big one, especially for case managers working with encampments, or other folks that are outreach workers, other folks that have the direct relationships with people, such as you all that are living in encampments. It can be tremendously helpful to actually, if your clients are willing to actually accompany them to health appointments that they might have, whether that's being with them if a street medicine provider comes out to them, or there's a mobile clinic, or especially if they do have to go to like a physical location, to a hospital or a clinic or a doctor's office. If you can go with them, again, if they're willing to have you with them, especially including like in the appointment itself, if they're willing, because you can really help advocate for your clients in terms of like care that they actually need, especially if they're going to see someone who's not particularly used to or good at, frankly, providing care to people experiencing homelessness. Some medical professionals are better than others at that, right? So you can really help be an advocate for them. You can ask questions that might not be occurring to your client for lots of different reasons. You can take notes about what the health provider is saying, so that there's like a record of maybe, diagnosis or things that they could do to help, parts of their treatment that the doctor is providing, that kind of thing. And then you can also help them with sort of whatever follow-up is needed from that appointment, right? You can help them keep track of what the doctors or the nurses or other folks have suggested to them. You can help track follow-up appointments. You can help sort of manage medications or prescriptions, that sort of thing. So if you have the capacity within your job and you have clients who you've built a relationship with that would be okay with this can be a really, really impactful strategy that can tremendously help folks that are needing to go to healthcare appointments.
I also want to make one connection, Jillian, to that. A lot of just described about the accompany, that last bullet, is the kind of things that enhanced care manager should and could be doing. So it may be interesting to think about to develop the enhanced care manager. Like if your organization isn't an enhanced care manager provider, maybe if you're doing this all the time, maybe you could be, or you could partner with an organization who is doing that. But Medicaid should be paying for someone to help people manage their prescriptions and track follow-up appointments and recommended courses of treatment. That's the kind of thing that Alyssa talked about. That is that role for that enhanced care manager. So just hold that as you get more experience with it, to hold those providers accountable and help them do this work, or think about whether that you're doing so much that work, maybe your organization would be a great organization to be an enhanced care manager organization.
Yeah, thanks very much, Julie. Especially the piece about, at least if your organization is not currently, or if you're not an enhanced care manager, even if at some point you or your organization might become one, in the meantime, if you are connecting your clients to the ECM benefit, it is very possible, including likely at this point, at least in the rollout, since as Alyssa said, it's pretty early on still, that if your person is enrolled in Medi-Cal and referred to ECM and gets a provider assigned to them, that person might not be experienced with working with folks experiencing homelessness. And so you can really help sort of like help them build that relationship with the folks you're working with, including, suggesting these kinds of things that, like, as they build the relationship with the person, you can really make clear, like, which of these kinds of things would be really beneficial to the person, and help support them to figure out how to do that well. So yeah, thanks, Julie. So I think we can go, the next slide just shares, again, there's some links to some resources. I didn't mention it by name, but the California Street Medicine Landscape Survey and Report was done by the University of Southern California and the California Healthcare Foundation relatively recently. So you can look at that. It has certainly not all, because they were using like particular definition of street medicine, but it has a lot of information about what different street medicine programs around the state looks like. So you can both use it to just, it's one place where you can look to see if you might have a local street medicine program that could be helpful for your clients. It also can just help you kind of like learn more about what street medicine looks like around the country. And I believe, I'm not sure if that report, but if you kind of search for that, I believe they're planning on kind of updating it. And so they, the USC, the University of Southern California School of Medicine, has a very robust street medicine program. And so they're, I think, trying to keep track of like maps of street medicine programs around the country. So if you go to the USC, we should add this link before we send it out to you. If you go to the USC Keck School of Medicine, like their street medicine program information has a lot of information about programs around the state you could use. And then you also can ask your local COC, local homeless response continuum of care, or your local health plans, because many health plans around the state have also been using some of this funding they have to actually like fund street medicine programs. And so your local health plan, especially if it's one of the, well, no matter who it is, might have information about whether there are street medicine programs locally that you might be able to connect, and they'd hopefully be able to know how to connect with them, especially if they're giving them some funding. And also your local hospitals might have connections to, or might even have folks that are, participating in street medicine. And I'm about to go through all kinds of different kinds of providers, and federally qualified health clinics are one. So like a community health center might be a program that are often the people that are sort of like basing, that street medicine programs are kind of been based out of traditionally. So, and then you can also literally just Google, when in doubt, right? Like any of the phrases we've used, when in doubt, Google that and your community, your county, and you might be able to find some programs locally that you can try to connect to. So the last sort of portion of content before we have the rest of the time for questions is a little bit of information about the types of local healthcare providers and resources that might be in your community and ways to find them. So there's 3 slides that have a lot of text on them. They look like this. There's 3 of these in a row. So I promise I'm not going to like read all of this out to you, but I do want to just highlight a few of them. And some of these, like community health center, healthcare for the homeless, rural clinics, those are all types of what's called federally qualified health centers, or FQHCs. And just like very briefly, federally qualified health centers are clinics or health centers that are intended to help serve like marginalized communities that are traditionally not accessing healthcare or that are underserved by the healthcare system. And so there's different kinds of them, but if you sort of like search for these sorts of programs, especially the phrase community health center or healthcare for the homeless, those are ones that are particularly meant to, obviously healthcare for the homeless are like specifically charged with, and they get actually extra funding to help work with folks experiencing homelessness and provide healthcare. And so especially those first two provider types are, if there's a street medicine program in your community, they might be connected to one of these kinds of clinics. But even just beyond street medicine, even though you all know by now how much I love it and I'll keep talking about it, obviously it's not the only option, but just in general, these programs might have really helpful clinic-based programs, right, to help, and they might have more flexible appointment times. They might just, they're really good partners to kind of reach out to and figure out like how best you can connect your clients to these providers. So if you're looking for, in addition to just the hospitals or sort of like free clinics in your community, those first two on here would be really valuable resources to actually connect to. And there are links for all of these to kind of look for your programs. Obviously, hospitals and emergency rooms are places where people experiencing homelessness often get a lot of their care for either lack of options or lack of awareness of other options. So because of that, some of the hospitals locally might already, like they're probably already seeing a lot of your folks, especially those with more complicated healthcare needs. And so they can be really helpful partners, because even if they're not, if they might be feeling like they're not doing a good job serving their folks, they might be overwhelmed or frustrated for various reasons because they're having folks that aren't having emergencies come in because those folks don't have another option that they can actually access. And so working with your local hospitals, especially those that have emergency departments, can be really great in terms of like trying to figure out better ways to get your clients and encampments access to care. And then there's also a particular type of hospital critical access. Like, again, we have links there where you can find your local providers. For folks who have behavioral health needs, so that would include substance use disorders or other mental health issues. Obviously, you're going to want to find like local providers that are specifically providing those services. And so there is a link where you can find some of that. You can also connect with your, I think this is on a later slide, but you can connect with your counties. Your county probably has or should have a behavioral health department or a division or mental health services. It might be called alcohol and other drugs, but there are different departments at both your county, and also there will be providers locally. And so again, this is another place where if you're having a hard time finding a place using that findtreatment.org, you can Google like behavioral health providers in your county or mental health providers or substance use, alcohol treatment, that kind of thing. Like just like search for those in your county name. And then finally, there's a couple types of providers we wanted to share here just for like particular like subpopulations. So there you can find Indian Health Service agencies in your community at that link. There are the VA, the Veterans Administration, has a health component as well. So if you're working with folks who are veterans, you can see if they're eligible for VA services, medical services. And then similarly, if you have someone who needs HIV or AIDS care, there's also specific providers to help folks that have those conditions. So you can look up those providers as well. And then I just have one final slide for providers that are not in the charts. So some of these we've mentioned before, but obviously your local, we've said this a bunch of times, right? Your local health plans, your MCPs can be really good partners, especially, and asking them who their ECM and community supports providers are, because as Alyssa mentioned, they all have to contract with providers to actually like provide those benefits and services. And so that will be different in every community. And so asking them like, who are the people, who are the organizations locally that are actually providing these services can be really helpful for you to know, to figure out who's providing healthcare and sort of related services in your community. Definitely encourage you to connect with your local public health department. So you can, again, you can find your local public health department via that link, but they provide health services, but also they can kind of help be like thought partners in figuring out how to connect folks to services. If, for example, during the height of the COVID pandemic, the public health departments were charged with doing a lot of obviously COVID response. And so depending on your community, many of them were the ones who were doing things like either helping to or providing the resources for like vaccine clinics or testing, or kind of like COVID care. So hopefully, unlike in years past, because of the pandemic, one thing that came out of it that can be useful is a lot of local public health departments got to know their local homeless response systems in a way that they hadn't before. And so they can be really good partners in trying to connect folks to care. So you can find out what services they offer, how to connect the folks who are living in encampments with public health services, things like that. And I mentioned similar to public health department, but not the same, of course, because nothing can be simple. Your county behavioral health services or your behavioral health department is another great county agency to connect with for folks who need those services. That is it. As far as content goes, we still have lots of time for questions if people have questions. I don't see any in the chat, but we have time if folks want to come off mute, or Julie or Alyssa, if you want to add anything before we fully open it up.
Yeah, I guess I would just say, you know we gave a broad overview, and as we were preparing the presentation, we gave a fair bit of thought to like, what is the content that's going to be most useful, particularly for folks supporting, encampments and doing that kind of work. But we really want to use this time to hear from you of like, what are the particular circumstances and situations, and where is stuff that we shared. You may be sitting there saying like, well, that's not really relevant or realistic given, how we deliver services or how we support people in encampments. So really want to open it up for you all to share your experiences, how this information sort of tracks to that experience, and welcome any kind of questions, perspectives, anything.
Good morning. I just want to share something. When you do the outreach at the encampment, and this is more safety, it's a good time to always go in the morning. Try not to go anything past in the afternoon, let's say 4 o'clock in the evening. It's not going to be safe if you go in by yourself. So when we do all this outreach, we do it in the morning, and there's other services and providing there. So there's a lot of going on from 8 o'clock all the way to 1 o'clock. And we go in groups because it's a little bit more safe. Remember, when we going in and they don't know you, because they know each other. There is a community that they know each other. We come in, they don't know. But when you start building relationship, a professional relationship, it makes it easier to deliver this service. However, it is safe to go in group, and it's safe to go in the morning. So try not to go anything after 3 o'clock or 2 o'clock. And if you do, go in a group. It's a big group. And if you have a contact person at the encampment that is from the county that works there, because they do have a little site office, try to communicate with them as well that you guys are going to be going in, so there's some type of communication. But like I said, for safety, try to go early in the morning when everybody's there providing the resources.
Thanks, Eric. I would love to add, I appreciate that, Eric. I also want to add, I've mentioned the USC, the University of Southern California Street Medicine Program. I'm bringing them up again because something Eric mentioned kind of made me think of this. They offer multiple times a year and in different locations throughout the state, and they have recently rolled out at least some of their dates and times for this for 2024. They offer free, it's called Street Medicine Foundations or Fundamental Training, but it's a really good training just for outreach in general. So I think like especially the first of 2 or 3 days is focused on all kinds of things. And Eric, some of the kind of like tips you were just giving reminded me of that training because I actually attended it last year, and the person who runs it does street medicine and has been doing it for a very, very long time in different locations. And she didn't specifically frame like the timing as safety necessarily, although they do talk about safety. But it was about just like getting to know your encampment and the people living in them, and like when they're going to be around and when they're receptive to and available for, for connecting with folks. But so, thanks, Julie. Julie put in the chat the link to the USC Street Medicine Program. But definitely, if you're interested, it's a free training. I think it is 3 days, but I think only the 3rd day really gets into like the nitty gritty of like delivering street medicine. So if you're an outreach worker who is not a street medicine provider, you can also just go to the first day or 2. And again, they do offer them around the state. So I would definitely like encourage them as a resource that you or your program might be interested in, and we can share it with the encampment resolution fund or like team to also like share that resource with you as well. So I appreciate you, Eric, for what you shared, and also because it reminded me of this resource I wanted to share also.
I'm curious if any of you who are working in encampments have had to deal with Medi-Cal renewals yet. If you've heard about people who had health coverage and then all of a sudden they discovered that they didn't, or they've been asking you to help them apply or renew. Just wondering if anyone's had any experience with that and is interested in coming off mute and sharing. Can you all do a show of hands if this is the first time you've heard about the Medi-Cal renewal process? Just do if you can do the reaction hand or a thumbs up or something. This is the first time. Great, thank you. I'm glad we did it then.
Yeah. Any other questions about either what we actually presented or honestly anything else healthcare related? Like Alyssa said, if you just want to, if you have an example of something that you've been kind of having challenges with and just want to talk through either with us or like the rest of the group that's on, it seems like you've got some really great resources amongst you all too.
We can stay on, but if there are no more questions, you all are welcome to get back a couple.
Wait, Julie, wait, there's a poll that Sarah wants to launch, so don't jump off quite yet.
Yes, okay, don't jump off, don't jump off. Sarah, thank you, Jillian. Whew.
Yeah. Oh wait, Sarah, before you do that, there's a question about a direct link to the page where they list the free trainings. I don't know whether they actually list them on a web page, but we have a Google Doc that we can share the link that like has all of them listed, like the whole schedule, and it links to like the agenda so you can see the specifics too. So we'll definitely share that out with the slides.
Yeah, we send out the recording, the slides after every training, and I'll make sure to add that resource as well so y'all can have that.
Thanks, Sarah.
Jillian, I think the poll might be launched by you.
Oh, only me? Okay, sorry. Oh, I didn't realize I had this complete control here. Okay, give me 1 sec, I'll find it. Okay, I am launching. Can you all see it?
Yeah.
Great. Okay, great. Yeah, so folks can take a few minutes to fill it out. That'd be great. And yeah, as Julie said, while you're filling out the poll or after, if you want to stick around, we can stick around to answer any other questions you have. But if you need to jump off after you complete the poll, then we will thank you for your time. Starting to see the responses come in, so thank you all so much for doing the poll. All right, I think if I'm understanding the poll right, I think that everyone who is on has completed it. So that's fantastic. Thank you all so much. Appreciate your time and attention and all the work you're doing. Again, as Julie said, if you have questions still, you want to chat with us, we can stick around for a little bit. But if you are all set, then we wish you a happy Friday.